Hey guys, so my main goal with this video is to address the basic anatomy as well as the physiology of the eye, and I'm hoping it gives you enough to appreciate some common conditions of the eye that you all have heard of. Included among those, nearsightedness, farsightedness. I want to address briefly cataracts and how that can be corrected. And I'll also address glaucoma as well. So all common conditions of the eye, and I think gaining an appreciation for the basic physiology of the eye will allow you to understand how those conditions manifest. So to start off, when you look at the eyeball, you can break it down into three key layers. So you have the fibrous layer, which is going to consist of the cornea and the sclera, and I'll go through each one of these systematically here. You have the vascular layer, which will include the iris, the colored part of your eye, little muscles called ciliary bodies, and lastly, the choroid. And then you have the neural piece of the eye, which is the retina itself. Now, another thing that's helpful to point out from this picture here, or this one, is that the lens is a key divide between the anterior cavity of the eye and the posterior cavity. I noted the retina a moment ago, and the retina lies all along the back of the eyeball here. So let's start off with the fibrous layer, and I can add some more details to this. So first of all, the sclera, that's what you're seeing here, and it wraps all the way around. It is incredibly tough, fibrous layer of the eye. If you think about how delicate some of the tissues are in the eye, it makes sense that you're going to have something a little bit more rigid to serve to protect the eye, to maintain its shape. In addition, when we move our eye, these muscles, these extrinsic eye muscles, need something relatively rigid to yank on so that we can look wherever we need to look. And so that's another key function of the sclera. You'll notice too that it's actually continuous with the dura mater of the brain in the posterior plane. The cornea is another piece of this fibrous layer. So the cornea is the most superficial layer of the eye. It's what we oftentimes scratch if we get something in our eye. We scratch our cornea. A key feature of the cornea is that it's transparent. Given that you have light coming in through the cornea, that's going to allow us to be able to direct and focus the light as well. So as I noted earlier, from an anatomical sense, the lens is going to divide the anterior cavity from the posterior cavity. But in terms of its physiology, so what it's going to do is it's going to actually change shape depending on if you're looking at something up close or far away. So you've undoubtedly witnessed somebody, an older individual who may have trouble focusing, maybe looking from something far away and then reading. And the reasoning behind that is because the lens actually becomes less elastic with age. So as we go from looking at something far away to looking at something up close, that lens has a harder time adapting to that change. It's less pliable. And so oftentimes reading glasses are warranted in an attempt to help compensate for that stiffer lens. So it is biconcave in shape, it's transparent, and it's avascular. The cornea is also avascular. I think that makes sense. If you had blood reaching the cornea as well as the lens, that blood would interfere with the passage of light through the cornea and all the way back to your retina. So I want to say a little bit more on the lens. So I had noted that it'll change shape depending on what you're looking at. That is, if you're looking at something up close or far away. And so if you look at how that happens, you actually have these little ciliary muscles that are anchored to the lens via these tiny little ciliary ligaments. And so when we are looking at something far away, those ciliary muscles relax and the lens becomes more flat. And in becoming flatter, it allows for that image to be focused exactly where we want it to be, on the back of the retina. Now, if we're looking at something up close, then it's going to be just the opposite. We'll see that those muscles are actually going to contract. The lens will bulge, and it will in turn allow that object to be focused also on the back of our retina. I think the connections here between the sympathetic and the parasympathetic systems are so interesting, and it makes sense from an evolutionary standpoint. When we are in a fight or flight situation, we want to be engaged looking at things in the distance, looking at something that may be a potential threat, looking at something that may be able to help us. And so I think it then makes sense that when our sympathetic system is activated, what naturally happens is our lens flattens so that we can see something far away. And when we're relaxed, it's easier for that lens to be able to bulge and allow us to look at something up close. When we're in fight or flight, again, historically, evolutionarily speaking, we're not going to be reading when we're in an emergency situation. What cataracts is it's a clouding of the lens itself. There are a variety of conditions that can contribute to this. Diabetes is a common one, also extensive UV exposure. So it's always important to wear your sunglasses, right, and to protect our eyes. But cataract surgery is actually an outpatient surgery that can be done relatively quickly with excellent results and outcome. And part of the reason for that is that this lens, because it's avascular, they'll actually go in and replace it with an artificial lens. And without that, without having to worry about the blood supply, they don't have to worry about matching or tissue rejection. And it tends to be a surgery that meets with a high degree of success. So moving on to the vascular layer. So two key functions of the choroid. Not only is it highly vascular, so it's going to supply blood to all of the layers of the eyeball, but it's also comprised of a brown pigment, which can help to reduce light scatter. So in many animals, that choroid, that brown pigment, is actually lined by what's called a lucidum, the shiny pearl-like nature to it. And what that's going to serve to do is to enhance any light that may be coming in dark situations. And so many animals have far, far superior night vision to us. And that lucidum is part of the reason for that. Rather than having solely this brown pigment to absorb light that may be scattering, they instead enhance light scatter by having this lucidum to reflect it. If you've ever taken a picture of your cat or your dog, that flash oftentimes captures the lucidum. And so that spooky look that you'll see in their eyes is nothing more than that flash hitting their lucidum. So the iris of the eye is also vascular. And the iris of the eye is the colored portion that we see. And within the iris, you have smooth muscles. And what those smooth muscles are going to do is they're going to regulate the size of the pupil. So depending on how bright the environment you're in, it will either constrict or dilate your pupil, and I'll address that a little bit more in a second. And then lastly, I noted this a little bit ago when we were talking about the lens, but the ciliary bodies, so these little ciliary muscles, ligaments, these are what are going to effectively pull on the lens to change its shape. So I want to elaborate a little bit more on how the iris works. So I noted that there's smooth muscle that makes up this iris, and so you can see the two layers here. And you may have heard that you can tell if somebody is lying by looking into their eyes and looking to see if there is pupil dilation. And there is some truth to that. So provided that they are nervous about telling that lie, that their system, that their body is in a fight or flight response, what you'll actually see is that those muscles in the iris contract and the pupil size increases, and you have more light coming into the eye. Conversely, when parasympathetic is most activated, muscles in the iris constrict and the pupil size is going to decrease as a consequence. Now, oftentimes I get the question about what determines the color of the iris itself. And it's very similar to what we saw with skin color. There are a variety of genetic components to this, but it ultimately comes down to pigmentation, how much melanin is going to be present in the iris of the eye. Blue eyes will have less pigment, brown eyes will have the most pigment. And you also see, just as we did with the skin, that the melanin does provide protection to the eyes as well. So blue eyes tend to be far more sensitive to UV light, and brown eyes have a bit more protection. So last up is the retina. So this is the neural layer of the eye. And there's a lot going on. The retina it has an important job. So I've got a couple slides to get at how it works. So first of all, just looking at the anatomy at the back of the eye. So the most posterior aspect of the eye, you have your photoreceptors. So you have rods, and the purple are supposed to be the rods, and you have cones. You have far more rods than you do cones. Rods are going to be responsible for detecting shades of gray, black and white, and the cones are going to be responsible for seeing color. The cones need a significant amount of light in order to be able to distinguish one color from the next, which is why when you're in a dim or dark room, that everything kind of looks to be the same color. They are really sensitive and again, need that bright light to be able to distinguish among the spectrum. The light will actually pass all the way through. The pathway of light will come all the way back to the eye. It'll hit these photoreceptors. And remember, these are nothing more than highly specialized neurons, and they will send an action potential passing this signal from the photoreceptors to what are called the bipolar cells. So these are all bipolar cells here. And then those bipolar cells then pass their message on to ganglion cells. And these ganglion cells, if you look at the axon of these ganglion cells, this is actually forming your optic nerve. So I have another picture that shows this nicely, but essentially the signal is going to spread from the photoreceptors to the bipolar cells to the ganglion cells. So whereas you have the pathway of light going this way, the pathway of the signal is going to go in the opposite direction. And one more thing here, the pigmented layer that you see on the back of the retina, this is just anterior to the choroid. And you see, again, that it's pigmented. So because of that, it is going to play a role in helping to absorb light. You also have some vitamin A that's going to be stored here. So the optic disc, or one's blind spot. So here it is in this graphic. So I've zoomed out here. You're seeing the retina. You can just barely make out the 3 layers of that retina that I was just showing. And as those ganglion cells, as their axons form the optic nerve, it has to have a place to exit, to start making its way towards the optic chiasm. And so the place where the optic nerve exits is your optic disc. And so because of the optic disc, if you look, there's no retina. It stops, right? We need a pathway for this optic nerve to be able to leave. And so because there's no retina, it's effectively a blind spot. So you don't have any photoreceptors in that region, and it's a point in space that we aren't aware of unless we specifically look for it. And there are some cool tests that you can easily do at home to look for your blind spot. This is one of them. It's in our periphery, about right here. And our brain is just constantly filling in this blind spot in our day-to-day lives. To say a little bit more about the rods and cones, we have about 250 million of them. Individuals who are colorblind, what typically happens is that they have a genetic mutation, or they're not making certain cones in the body. So they may not be sensitive to all aspects of the spectrum. So some interesting clinical examples here that many of us can relate to. I'm definitely nearsighted myself. And so if you are nearsighted, so myopia, what that really means is that without corrective lens or contacts or surgery, when you look at something far away, that object, we want it to be focused right on the retina. We want that light to be directed to those photoreceptors, but instead what happens is the image lands just anterior to the retina, and so we're not able to see those things far away clearly. And so what a corrective lens will do is it will allow that light to effectively shine right on the back of the retina. So in many cases with myopia, the shape of the eyeball is slightly oblong. So there's not much we can do to change the shape of one's eyeball. Usually laser surgery will aim at actually shaving the cornea itself. So they'll slice the cornea, and then they'll remove some of the deeper parts of the cornea itself, and they'll seal the edges, and you can see that it typically starts to fuse within about 72 hours. So it's another surgery that is remarkably fast with really high success rates. So conversely, if you're farsighted, so the image actually focuses behind the retina, and again, a corrective lens within enable that image to be focused right on the retina. So to elaborate a little bit more on the visual pathways, so I think many of us have a sense for the fact that what we see in our left eye is going to be perceived by the right hemisphere. It's going to pass to that right occipital lobe, and conversely on the other side. And so what you're seeing here is simply that path. So light hits the photoreceptors, the bipolar cells, the ganglion cells. It leaves the optic nerve, passes through the optic chiasm. So that's where it crosses. And then, right, the difference between a nerve and a tract, they're both bundles of axons. The nerve is PNS, the tract is CNS, right? So we're deep in the brain here. And that optic tract will pass that information through the thalamus. Some of it will divert to the superior colliculi. If you recall, that those are regions responsible for visual reflexes. And then most of that information is going to pass to that occipital lobe. It will be interpreted. The humors or the fluids of the eye. So you have what's called the vitreous humor, which is actually going to be in the posterior aspect of the eye. So posterior to the lens, remember this is our divide. So the posterior segment, here's our vitreous humor. And then the aqueous humor is going to be in the anterior portion of the eye. So the vitreous humor is kind of gelatinous in nature. And what it's going to do is it's going to hold the retina in place. So it contributes to that intraocular within the eye pressure that is oftentimes tested when you go to the eye doctor. And this vitreous humor, it lasts a lifetime. In contrast with aqueous humor, this plasma is replaced quite frequently. It's continuously forming. And so this aqueous humor, you can see it's going to work to supply nutrients and oxygen to the lens, the cornea, the retina. So it's awfully important. And it's going to remove waste. And so an important clinical condition that's incredibly relevant here is glaucoma. So what happens with glaucoma is you actually have that aqueous humor, the drainage of that aqueous humor. We're zooming in on this piece here. It's blocked, so you don't get that drainage. And as a consequence, you have pressure building not only in the anterior aspect, but it's perhaps more importantly going to press on the posterior aspect of the eye. And as that intraocular pressure builds in that vitreous humor, it's going to press on our retina, and it can compress the optic nerve, ultimately causing damage and even blindness in some cases. And then the last thing I want to note is one of the key accessory structures of the eye. So you've got your eyebrows, you've got your eyelids, which are all going to work to protect the eye, to keep debris out of your eye. The lacrimal glands. So here they are. And what they're going to do is they're going to produce tears. And tears play a huge role in our immune system. If you think about how infections, viruses spread, it's oftentimes through our eyes, nose, mouth, etc., right? But this is a place in the body that we have that's more susceptible to infection. And so one of the benefits of these tears is they have lysozymes in them. And those lysozymes can work to fight bacteria. Tears also provide nutrients and oxygen. So in people who have dry eye, they may blink frequently, and it can become quite disruptive and even damaging to the eye if that's chronic in nature. If you look, you can see that there is a lacrimal sac and a nasolacrimal duct. And so naso, nose, lacrimal, right? So connecting to the tear ducts, if you will. And so you may have wondered why it is that an individual's nose runs when they cry. And it's simply because the tears will actually drain through this nasolacrimal duct. Conjunctiva. So conjunctiva refers to the white mucous membrane that's going to cover your eyelids, the white part of the eye and the eyelids, and this produces a lubricating mucus. And conjunctivitis, pink eye, is when the whites of your eye and that structure becomes infected. So hopefully that was a useful overview for you all and gives you enough anatomy and physiology to appreciate some common clinical conditions that we see.